Today, we are very fortunate to have a true nursing leader with us to deliver today's presentation on influencing healthcare and governance. Dr. Ann Scott Blouin is founder and president of PSQ Advisory, a consultancy that helps healthcare organizations reduce costs, improve patient safety, and increase care quality by proactively managing risk. After earning her bachelor's and master's degrees in nursing and working in care delivery for 15 years, Dr. Blouin came to UIC to earn a PhD in nursing as well as an MBA at the same time. After that, she joined the world of healthcare consulting, holding increasingly prominent leadership positions at global consultancies, including Ernst & Young, Huron, and Deloitte. Before founding PSQ Advisory, Dr. Blouin was Executive Vice President of Customer Relations at the Joint Commission, the nation's oldest and largest accrediting body in healthcare. Most relevant to today's topic, Dr. Blouin is a passionate believer that the voices of nurses are critically needed on boards of all kinds. She herself sits on boards of multiple organizations, including the Institute for Healthcare Improvement and Sign Group, a holding company of skilled nursing and senior living facilities, and several startups in the healthcare arena. She's also an advisor with Governmental, which works to strengthen the boards of community and healthcare nonprofits. Please join me in welcoming Dr. Ann Scott Blouin.
Thank you, Sarah, and good afternoon to everyone. I'm hoping that this conversation will help actually enlighten you a little bit on the role of nurses on boards. I would say to you that my belief is that nurses can participate throughout their lifespan in so many different ways. My clinical and administrative background includes being a chief nursing officer, being a nurse manager, a nurse clinician, a staff nurse, as well as a chief operating officer. And now, as I've retired from my prior life at the Joint Commission, where I ran the operations and then customer relations, I've really focused on governance, on healthcare governance. And we'll talk today about nurses on boards, why it's so important to have nurses' voices on boards. You'll see the objectives here. I'm not going to read them to you. I want to be sure we have lots of time for questions and discussion. Hopefully, if you're listening in, you have some interest in possibly joining a board, either now or in the future. We'll talk about different types of boards that nurses can serve on. Specifically, I do want to cover two areas. I want to talk about, as Sarah mentioned, I'm on the Institute for Healthcare Improvements board, and I actually chair the governance and nominating committee for the Institute for Healthcare Improvement. I serve on that committee as well for the Ensign Group, and I chair the quality and compliance committee for the Ensign Group. So nurses' voices are very, very important on boards. I'm also going to talk about the American Nurses Association Nurses on Boards Coalition, the progress that we've made nationally on getting nurses on boards, all different types of boards, and the services they offer. I'd like to stop for a moment and thank Lori Benson from the American Nurses Association, who provided some of the background slides that you'll see on the Nurses on Board Coalition. That work started, actually, many of us will remember, if we're old enough, will remember the Future of Nursing, the Institute of Medicine, now National Academy of Medicine, and Robert Wood Johnson's seminal work on the future of nursing and leading change. In that document, they called for nurses, additional nurses across the United States to serve on boards. As many of us know, physicians often serve on boards, but nurses weren't necessarily positioned, nor, by the way, were women. And I can talk about women on corporate boards as well if you have any interest in that topic. But nurses have a unique set of skills that they bring to boards. You'll see listed here, and again, this is a ANA Nurses on Board Coalition slide. These are some of the special skill sets that nurses bring to boards. I would say, and most of you know the work that shows that every year nurses are the most trusted. They're more trusted than any other profession to try to do the right things. And I think healthcare governance is an area that really comes to shine. We'll talk later, and I think Sarah's going to ask, or we'll discuss a question about particular circumstances that can be a little bit interesting for nurses when they serve on boards. This is the competency model that the Nurses on Board Coalition has. And this is free. You don't have to be a member of the American Nurses Association in order to access this work with Lori Benson and the work that's been done. Really started, I think, under Marla Weston and has continued to do wonderful, wonderful things. There are three components of board competencies that the Nurses on Board Coalition, specifically their framework, looks at. The leadership of organizations, and nurses are highly skilled at all levels, at the patient care level, the direct care level, all the way up through the CEO level at leading organizations. We also have a role that we take seriously in the leadership of our profession and our civic and community activities. And that's one area that nurses frequently serve on, whether it's a PTA board or a church board, advisory group board. I'm currently serving, now that I don't travel full time as I did previously, I'm serving on our local church's St. Vincent de Paul board that allows people of need to get some resources. And then at the very top is the leadership of self, lifelong learning, the ability to understand your personal style and how that can be an asset or liability, important in both cases, and to understand, of course, the background and principles of management versus governance. We'll talk a bit about that. This is an example of a core competency matrix or Excel spreadsheet, if you want to use that term. On any of the boards that I serve on, the governance nominating committee is responsible for adding new members once people's term limits have been exhausted or new skill sets are needed. So for example, on several of the boards that I sit on, skill sets around digital innovation, around cybersecurity, around technology and use of technology in patient care are important new competencies that board members are being solicited for. This is the current state that I wanted to share with you as of the date that Lori shared, which was in August of this year. This, and you can register on this, you'll see the link to that in the references. There are currently almost 23,000 individual nurses registered who'd like to serve on boards or are serving on boards. You'll see the second statistic there. More than 10,000 nurses currently serve on boards. Some serve on more than one board, as do I. But you'll see that the goal that was put forth in the Future of Nursing IOM Robert Wood Johnson work was 10,000 nurses by 2020. So we certainly, despite COVID and despite all the challenges we've had, we've actually been able to achieve that goal, at least in 2021. There are 14,000 nurses plus who have indicated a willingness of wanting to serve. And some are serving on one board, but would like to serve on more than one board. These are the website resources from the Nurses on Board Coalition from the American Nurse Association, the Readiness Assessment tool, which is actually courtesy of NOBC and North Carolina Nurse Association, and then the core competencies, kind of an action plan to move from the assessment, looking at how do you actually get on a board, because it is sometimes not dissimilar from interviewing for a job, which I found really interesting when I first started to look at this. And then a simulation experience, which is actually from Ohio Action Coalition. So there's lots of resources there. And again, you don't have to be an American Nurse Association member if you're not, to be able to help access this. Now I'd like to move into the typical board types and the committees. One of the early ways to get involved, if you think you're interested in governance versus management, and they are two different functions, is to actually serve on an advisory board. Early on in my career, I served on an advisory board when I was a chief nursing officer for a local senior citizen board, citizen group. And I was on their board. It was a group on aging, and actually gave me some of my first insights into geriatrics in the community outside the health system setting. There are nonprofit healthcare organization boards, and they are easier typically to get on than the publicly traded company board. There are also nonprofit community, religious or civic organizations, as I mentioned, churches, PTAs, local civic centers, senior centers, et cetera, Professional association groups like alumni groups. We'll talk about the University of Illinois College of Nursing Alumni Board at the end, the American Nurse Association, the American Organization of Nurse Leaders, and other professional groups, such as the Joint Commission, which does have nursing representation on its board. And then, as I mentioned, startup companies. And this is an interesting one. If you were to say to me that I would have been approached by a half dozen startup, primarily technology startup companies in healthcare to become a board member when I retired from the Joint Commission, I would have said, but I'm not an IT expert. It's not the IT expertise they were looking for. It was the healthcare leadership background and the clinical knowledge that comes from being a registered nurse. So that's a very interesting, relatively new phenomena in the last decade. The usual committees that boards have, and this differs by board, but the typical ones are the Governance Nominating Committee, the Quality or Quality Compliance Committee, which nurses are ideally suited, obviously, to serve on, the Finance Committee, the Audit Committee, Human Resources. Some boards, especially nonprofit boards, may have a fundraising or foundation function, and then some boards, not all, have an executive committee. So let's talk about what are the responsibilities of all board members, nurses and others who serve on boards. Then this is really the difference between right here, management and governance. So governance is responsible for what's called the fiduciary responsibilities, which people believe means financial. It's actually way more than financial. It includes quality of patient care, which I think we're uniquely capable, along with some of our physician colleagues and others, to serve on boards. It does have the financial responsibility overall. Most importantly, it's responsible to hire, fire, and evaluate the chief executive officer of the company, and to review the mission, vision, and values. The board is responsible for itself. It's a self-governing group of people. And once someone is appointed to a board, assuming there is an orientation, which there should be, about what the responsibilities of that particular organization is, it helps to understand that actually way in advance. You'll see a slide coming up in just a little bit that talks about if you're interested in joining a board, what do you want to do in advance? Because as much as they're interviewing or considering you for board membership, so too are you considering them. And I don't think I understood that earlier on in my career. I served on a federally qualified healthcare center when I worked at Northwestern many years ago at the Women's Hospital at Prentice. And I'm not totally sure I looked at it as kind of a two-way street. I was glad to serve. We had a facility in Cabrini Green at the time, and I was very pleased to serve, but it really is a two-way street. You're looking at what you can bring to them and what are they like, and then they're looking at what are you like and what can you bring to them. This is an old study, but I wanted to bring it in, not just because I really like Ashish Jha, Dr. Jha, whom we've seen a lot during the pandemic on television, I think. It's from 2010, but it's extremely important to understand, and this was one of the driving factors behind the Institute for Healthcare Improvement's work in governance that I'll talk about in just a second. But in 2010, fewer than half of nonprofit hospital boards really ranked quality among the top two priorities. In other words, financial was looked at always as first. And by the way, as an aside, when I was at the Joint Commission and the surveyors reported to me, one way the surveyors could tell whether or not a hospital board looked at quality and safety of patient care was whether or not it was afforded time on the board agenda. And was it last on the agenda? Did it frequently get bumped from discussion? So the importance of that, of discussing that, many people like Gary Kaplan and others at Virginia Mason have actually had patient stories, both good and bad, at their board meetings to try to bring home right in the beginning of the board meeting the importance of quality and patient safety. In this study, only about a third of the executives at that time, the hospital board members rather, received training on clinical quality. That's a problem because people that are not nurses or physicians by background need to have some understanding of what they're looking at in terms of the data, the performance indicators, whether those are CMS or others. So hospitals, not surprisingly in the study, hospitals that perform high on quality, these quality metrics, have a correlation with the amount of board time spent on discussing quality. This is an older slide from 2006, I believe, but I think you'll find it really interesting. This is true of Moodys, Standard & Poor, and Fitch, which are the prime 3 rating agencies. Every hospital and other organizations are given credit ratings, which allows them to borrow money either at a lower interest rate or a higher interest rate. And when Moodys and S&P and Fitch looked at this, they identified that when there was a quality-focused strategy of a hospital or health system, those systems tended to do better. And that indeed was the case when we looked at this when I was at the Joint Commission. Now, Institute for Healthcare Improvement looked at the background, the fact that there wasn't a lot of focus on quality spent with healthcare governing boards, their discussions for their board agendas, and their retreats. So what they did is, working together with a multidisciplinary group, they actually studied what was the framework for a board to look at governing quality, not financial, but quality. And there were 3 content areas, if you would. Core quality knowledge, that's back to the, some of the things that we'll talk about in a second, and I've got a slide for each of these. Core knowledge about performance improvement. How do you improve performance? What are the tools? What are the systems? What are the techniques? And then lastly, and most importantly in many ways, the board culture and whether or not they're committed to quality. Is it lip service or is it real? So the first one is the quality knowledge. And just to simplify this and really make this patient-centered, it's around what some would say, well, aren't these the old, safe, equitable, high quality care? And the answer is yes. It is keep me safe, safe care every single time, provide me with the right care, effective care and appropriate care for me as an individual, not just, all the patients who have congestive heart failure. Treat me with respect, equitable and patient-centered care, family-centered care. Help me navigate my care. We are so used to health systems and we've lived within them for so long that we forget that it's super scary sometimes and very difficult to navigate care coordination. So things fall between the cracks, as we know. And then help me stay well. Please help me with either my desire to be more physically fit, to manage my chronic diseases, whatever. The second content area that IHI studied, and by the way, this is free. This framework is free on www.ihi.org. If you do a search on governance framework for quality or quality governance framework, and I believe this is in the references, my references out as well. But this is all free. You can access any of the work that's done by IHI. The second area is what are the systems for improvement? And this is, discussing with the board, what does your health system or hospital or clinic or ambulatory surgical center use? Do you use PDCA or Six Sigma, or what types of tools do you use? And actually sharing metrics and areas that you need to improve in, as well as success stories there. So understanding who and how quality evaluation occurs at your organization. And then the last one, which is really important, is the culture of quality, which relates strongly, as you know, to the culture of safety. So safety culture is around what happens when someone identifies a potential problem for patient care, whether it's a system problem or a human problem. Is it related to the way something is constructed or technology, or a safety culture issue around the team? And then what's done with that data? How is it studied and how is it resolved? And it's generally not always clear to the board, having had this happen to me personally as a board member, not recently, the exact culture of the organization without getting some insights into employee satisfaction, retention, turnover, statistics that we're very familiar with in nursing. The culture is really where the shared values and beliefs of an organization are, and it's the one that is somewhat intangible, but when it's not working well, it results in dissatisfaction of the staff and turnover. So this is an important piece. We usually marry this now with joy in work. We know that 1 out of every 5 healthcare workers has left their jobs during the pandemic. So this is a super important area. It's actually the focus of my dissertation. I looked at UIC, I looked at organizational culture in hospitals that had nursing shared governance. That was my dissertation. So as you know, you can change people's behaviors. You can say, Anne, I don't like it that you're wearing a red top today, but you can't change my underlying values, which come from our family, our community, our religion, our how we grow up. So now we'll talk about some things that all healthcare board members sort of have to do. And these are things that you come with a lot of this as a nurse, but I would tell you that I've learned huge amounts in all of my board seats about things I didn't know. So back to the lifelong learning comment, definitely relevant. Understanding not just the metrics, but what are preventable things versus things that couldn't be prevented. So the pandemic is unlikely to have been able to be prevented, but mitigating it and sorry for the public service announcement for vaccines, but as soon as possible, getting people vaccinated is important. Supporting a culture of safety and understanding what that looks like for the staff of the organization whose board you serve on is important. What are the costs of harm? There's some very good work done by AHRQ, the Agency for Healthcare Research and Quality. I would be glad to share that with anyone that's interested, that actually talks about the financial cost associated with each CLABSI, CAUTI, VAP, et cetera, that we know well. You have to be able to understand how patients are cared for in whatever you're serving. If it's a clinic or an ambulatory surgical center, actually spending a day following staff around if that's permitted, or learning from staff directly. We at IHI, we do something we did prior to the pandemic, something kind of neat. A staff member would come in and meet with us while we were eating a salad for lunch, and they would talk about their work there and what they did. What were some of the barriers to them improving their workflows and processes? It was great because it really helped us get to know the staff, and it helped us to get to know the sort of the things that you don't as a board member as opposed to a manager. The other thing is to understand how patient feedback is really collected, and we all know about HCAHPS scores, but is there a system of transparency? How is that done? If it's not a transparent system because of the philosophy of management and the board, do patients know about harm events? How does that impact diversity? There's a lot of work now done. I'm sure you're reading it. I'm reading it every day about diversity. Most boards have had some. We just finished ours last spring. Diversity, equity, inclusion training from an outside consultant to understand how that affects our role with the Institute for Healthcare Improvement. Very, very important. In some places in the United States, there's actually laws now. California has a law about not just diversity of gender on the board, but diversity of ethnicity or racial background as well. So understanding diversity is important. We know that long wait times, ineffective transitions, and poor care coordination leads to problems for patients and their families. So understanding that, especially complex care patients, and asking questions, not at the level of detail that you would as a nurse or a nurse leader, nurse manager, but at the level that says, how are we looking at this? Do we consider this a problem? Have we gotten better or worse in this area? And understanding the impact upon the bottom line, actually, because CMS penalizes hospitals and other providers for poor care. So understanding that and understanding exactly how that occurs is helpful. Understanding the digital strategies and cybersecurity has become increasingly more important these days as cybersecurity violations, bad players have continued to increase. understanding what's the difference between working with a community and population health and an individual within that population, and then understanding population segments. And I listened to an interesting webinar yesterday through ACHE, American College of Healthcare Execs, from Roper St. Francis Health System in the Carolinas. And it really had a very interesting talk about it. The data analyst talked about, it's not just the zip code we have to look at, it's within zip codes, there can be all different kinds of diversity in terms of disease states and social determinants of health. And then understanding the types of contracts and financial risk, if you're taking capitation or covered lives, and that's how you're managing some of your patient that you serve in terms of contracts for managed care, that's important to understand. Now, I mentioned this before, and I want to mention it again. It's important for you to do your homework. If you're looking at an organization and serving on the board, it's a two-way street. They're looking at you, but you're looking at them. And here are some of the kinds of things that you want to be able to assess. And I actually spent a lot of time thinking about this for this presentation. I want to mention a couple that are really, really important. Liability coverage. You always want to be sure that you have liability coverage because boards are increasingly sued, both public boards and nonprofit boards. So you want to be sure that you've got liability coverage as part of your service to the board. Nonprofit boards typically don't compensate board members, but they may or may not, some do, pay expenses if there's travel expenses to meetings, for example. You certainly want to understand the financial condition of that organization. If they're in a turnaround situation where they have to cut costs and turn around their organization, which one of the boards I served on was in that situation, you want to be able to understand that so you are aware of it and aware of what you're getting into. These are the references that I pulled together, and you'll see the Lori Benson Nurses on Board Coalition, the website right up there under the American Nurse Association. You'll also see the IHI white paper there with the web link to that. Before I open this, and Sarah and I decided that we would do about a half an hour presentation and leave about a half an hour for discussion and questions, I wanted to just mention that UIC Nursing has a number of ways that you can get involved. I've actually been involved in a number of ways over the years. The first is to join the Nursing Alumni Board, and Sarah can help if someone's interested in that and you're an alum of UIC College of Nursing. Please, we are very interested in having you join us. The second thing, and I've done this with great pleasure, is to serve as an alumni mentor. If you're a seasoned exec or leader or mid-career, help someone who's climbing up the ladder behind you and help them, mentor them. It is not very time consuming, but it's a wonderful way to get to meet new people and help. There's also ways to need nurses now. I personally have recruited 4 people on my block that I live in suburban Chicago to become registered nurses. I'm so enthusiastic about nursing that it's fun and easy to recruit other people who are interested in serving others and becoming a nurse. And then there's a couple others to recognize other fellow alum, and you'll see Sarah's contact information there. And then help the college's Giving Tuesday efforts. Many of you know that it's hard, it's always hard with nonprofit organizations to be able to have enough money for scholarships, etc. And then just as a last, before we open it for questions, for those of you interested, there'll be another on duty in January on restorative justice and resiliency. So Sarah, I think we can open it now for discussion and questions if that's okay.
Yes. If anyone has any comments or any questions, please submit them in the chat field. For now, let's get started with a couple questions that were sent ahead of time. Can you comment on the difference between governance and management?
Yes, that's a really important question. Thank you. Governance really is the oversight responsibility for an entity, an organization, whether it's nonprofit or for-profit, publicly traded, or an advisory group. It's really looking at the total picture at an oversight level, it is very different from management, which is the day-to-day assumption of operations, finance, human resources, the nitty-gritty. So the board has a role in leadership, and management has a role in leadership. The board is considered, by at least the Joint Commission's definition, to be part of healthcare leadership, along with the medical staff and the management at all levels. So management, think day-to-day operations, governance, think fiduciary, meaning more than just financial oversight.
Okay. Let's see. How did you start getting your feet wet with your board work?
Oh, that's a great question. The easiest way to start, if you've never been on a board before, in my experience, is actually to join an advisory group or a community board, which is they tend to be a little more informal as opposed to formal structured boards. But it's a good way to begin to understand how boards work, because they have a different way of working. They typically meet quarterly, is the most common sequence or cadence for board meetings. And they may or may not have a board retreat where they talk about strategic planning, which is one of the core functions, along with management, to come up with a strategic plan for short-term and long-term health of the organization. So an advisory group, and the advisory group could be a church advisory group, a PTA, a civic organization, Kiwanis Club, whatever. Those are the easiest ways to sort of get started. I personally started on two boards, the federally healthcare qualified clinic called Near North Health Services Corporation when I was at Northwestern at Prentice. And then I joined, when I was chief nurse, the Blouin Cicero Council on Aging Board, which was a community group that served senior citizens, Meals on Wheels, social services for impoverished elderly people, homelessness to prevent homelessness. So many of the things that we deal with in social determinants of health, we dealt with on the Blouin Cicero Council on Aging. So those are easier ways to get started than to maybe get on a health system board, which takes a little more, typically a little more experience.
Great. Okay. Yeah, here's something that came in from the chat. You did not mention governmental boards, which are generally political appointments. These have some unique challenges.
Yes, thank you. They do have some unique challenges. Serving on the board of a governmental agency, whether that's some of the ones we know well, like CMS or HHS, or some of the state governmental, the Illinois Department of Professional Regulation, for example, has a board, as does the group that looks at the certificate of need. Those are very interesting boards, often political appointees, and often come with either a very specific focus, regulatory or governmental in nature. So the board at the Joint Commission, which is not a government agency, it's a voluntary accrediting organization, but it's an interesting board because, and this is public information or I wouldn't share it, it's called a constituency board. So there are a number of members that are appointed by the American Hospital Association, the American Medical Association, and several other physician groups. And then there are nurse colleagues that are appointed both as at-large members and then frequently coming from the AHA, the American Hospital Association. So those boards carry a little bit different type of political perspective, frankly, and political intrigue than some of the local nonprofit boards. Very good point. Thanks for raising that.
All right. What are a few ethical issues that members on the board face?
Yeah, that's a good one. And of course, with the pandemic, all of the boards I've served on have had some very significant issues facing them. I'll mention a couple. In general, the ethical issues are you resourcing the organization properly to do the mission vision, to accomplish the mission and vision? In other words, is the budget that goes through the board, because the board does approve the budget in all organizations, does that budget sufficiently resource what is needed? And how do you know that? Does your budget sufficiently resource your strategic plan? Is another key question. Those are ethical issues, because if you don't give management enough resources and approve that budget, you have to go back and question, is your scope of services correct? Is your mission and vision and values correct? So that's one big ethical issue. And resources is everything from material resources to human resources, staffing, always a key issue for us as nurses. One of the issues that came up during the pandemic was on several of the boards is, did we have enough PPE for our nursing staff and others taking care of patients on the public board that I sit on? Other ethical issues are, how did we want to approach the policy around mandatory vaccinations and masking? Those are, I believe, ethical issues, and they're issues that are important for the boards to have a frank discussion with management about what are we considering, what's in the regulatory environment right now, what are the liability issues associated with that. So those are definitely some ethical issues. The other ethical issue I think that's very common on healthcare boards is when there is something that is untoward that occurs, whether it's a harm event that's serious for patient care, or whether it's a personnel matter, sexual harassment, or other types of things. What are the policies? What are the practices, and how is that handled by management? So those are big ethical issues that come to bear at the board meeting. Not the day-to-day stuff in terms of personnel management, but significant issues.
Okay. How does one find out what boards are looking for in members?
Good question. One way, obviously, is to register your interest in Nurses on Boards Coalition. I had the great pleasure. It was a very nice thing. One of the board members at the Joint Commission asked me if I would serve on his board, his hospital board in Ohio, but I couldn't because of conflict of interest. I was an executive at the Joint Commission, and we accredited that hospital, so that wouldn't have been okay. But I connected him to Nurses on Board Coalition, and he found someone within the state of Ohio, a nurse leader, who was very interested in board service, and she has done a great job for this health service, or excuse me, health system. So I would say keep your ears open is one way. Another way is to tell people that you know are serving on boards that you would be interested in joining a board. Certainly indicating to the CEO if you have contacts with the CEO of a local community organization. Many places have an area that's called board affairs or board relations that comes out of the CEO's office if it's a large company. So that's another way, but usually cold calls are not generally the most effective way. So I personally, if I was interested in serving on a board, I'd keep my ears open. I'd talk to my friends and family and my nurse colleagues that I'm interested, because I'm at the point now, for example, I can't serve on any more healthcare technology boards. I don't have any more bandwidth. So a couple of my colleagues, physician and nurse colleagues, have said, gee, Ann, if something like this, you hear something like this, let me know, because I'd be interested in serving. So talk to your colleagues as well as registering on the Nurses on Board Coalition.
Okay, based on your experience, can you share a story where your role as a nurse truly counted as a board member?
Yes, I would be happy to do that. I think that probably the story that is the most relevant was the story around the pandemic. And I believed and strongly believe that all the people caring for patients should be vaccinated, unless there is some really bizarre medical thing that prohibits that vaccination. So I serve as the only clinician on one of the boards I serve on, and I raised that issue, and I raised it in a strategic and respectful manner. But the importance of mandatory vaccination, both for the patients that were served, but really the staff was very, very important. And did we want to take a lead versus our competitors, or did we want to follow and wait for the government to make a decision? That kind of a strategic discussion, I think, was enhanced by frankly, my nursing background and my ability to bring that to the table. The other time that was important was when we were talking, actually, the board frequently approves compensation for senior leaders. And there was one senior leader who was strongly against vaccination. And I put forth in a respectful manner, again, that I just couldn't sign off on an incentive bonus for that particular person, even though he had done many other wonderful things. He actually was now working against the policy of the organization. So my nursing background and my ability to talk about the impact of immunity and the impact of vaccination on disease contagion and infection control became very relevant in that conversation.
Thank you. You mentioned a safety culture that depends on mission, vision, and values. What are good retention strategies for organizations that you've learned?
Great question. I think there's never enough retention strategies. The first one I think that I would say to you all is, whenever you're in a position of leadership, whether it's a nurse manager, director of nursing, chief nurse, whatever that role may be, supervisor, talking frequently, and I do mean frequently, more than once a year performance review to the staff to find out how they're doing, giving them a pizza party when it's been a good job. Many people have said, save the pizza. Instead, get me the needed supplies I have, pay me properly. That's really what I want. So understanding really what's driving satisfaction or dissatisfaction in the staff, not just waiting for an employee satisfaction survey, is sort of retention strategy number one. Number two, something I did as a chief nurse many years ago when I was a chief nursing officer was I called it have it your way. Any nurse that was a wonderful, competent nurse, I built a registry of nursing staff. We call it a flow pool registry, whatever you want to call it, in-house, as opposed to using agency. My number one objective was to get rid of agency because it was during a nursing shortage in Chicago, and I really did not want to use agency. And I mean no offense to people that work in Travelers or agency, but I wanted my own staff. I wanted my own staff to learn our policies, our procedures, become part of our culture. So I called it Have It Your Way. And I created a registry that allowed us to recruit 300 nurses in a relatively short period of time from our competitors to come and try this particular hospital. Now, about 100 of them stayed. The other 200 probably tried it and said, not for me, or I'm too busy, I don't want to work 2 jobs or whatever. But being flexible and understanding what's important to the staff where you can. I was amused by a conversation with a colleague who was not a nurse, talking about could her daughter, who has a young baby, who has basically an office job, could she do a hybrid working arrangement? And the employer is leaning toward, no, you have to be in the office full time if you want to work here. That's kind of the old world. We don't have that world anymore. So working at home, if you're in a leadership position occasionally, makes sense. Can't do that with patient care. They have to be at, on site, whether it's a clinic or acute care setting or long-term care setting. So making sure that the staff has absolutely everything that they need to do good care, and that there's enough support systems. One of the places where I'm a board member, and I'm very lucky, colleagues of the nurses actually looked at what the nurses were doing, and they picked up about 20% of what the registered nurses were doing that were not within the scope of practice that had to be part of an RN's duties. So these therapists actually picked up on other types of things to support the nursing staff to do what only they could do. I thought that was remarkable. So being creative obviously always helps, and being competitive with wages and salaries is critically important. I hope that helped answer that question. It's a tough one, and there is no single magic strategy or initiative, which we all know on the phone.
All right. That concludes our Q&A portion of this webinar. Thank you once again, Dr. Blouin, for this discussion. Let's all just give her a round of applause, whether with the reaction button or however you see fit.
Thank you very much for having me. And I hope all of you will consider joining a board. It's really important as nurses, our voices need to be heard.
And also just a few closing remarks before we conclude today's webinar. Again, this event was one of our series called On Duty. Please visit go.uic.edu/news-events to see upcoming events, not only in this series, but as well as other Alumni and Friends events that we are hosting. The next On Duty, as Anne mentioned earlier, is January 27th, where we'll have Professor Jerry Gorman delivering a session on restorative justice and resilience. Also, Dr. Blouin reminded us today how amazing our alumni are. So please consider whether you know a UIC Nursing alum who would make a great candidate for one of our college's alumni awards. I know Anne already shared that information on the slide, but I did share my email address in the chat field. So anyone that is interested in recognizing any of our fabulous alum, please just shoot me an email. Nominations are due February 15th. You can also get to our Alumni Awards information on our website. It's go.uic.edu/nursing alum awards. And that's it for today. Thank you so much for being with us. Have a great rest of your afternoon.